Hi everyone, I am Dr. Lisa Sundahl Platt. Thank you all for taking the time to view my presentation regarding how we may better use design interventions as a moderator to disease-causing pathogen spread, especially within acute healthcare environments. In this presentation, I will explain how using socio-ecological variables to inform the planning of environment of care safety priorities may offer better predictive insight to the efficacy of built environments to prevent antimicrobial resistant pathogen propagation, and thus greater reliability in stemming the spread of infection. So to introduce myself, I am a researcher within the University of Florida's College of Design, Construction, and Planning, and my lab is based in the Florida Institute for Built Environment Resilience, or FIBER, which is how it is more widely known here at UF. And a selection of our institute's core area of research include varied topics such as the Florida Resilient Cities Program, advanced modular housing design, long-term past and future settlement landscape design, narratives of risk and resilience, intelligent disaster and emergency response, and finally, infection prevention through design, which is what I'm here to talk to you about today. I am also an assistant professor within the Department of Interior Design, and my professional life for over 2 decades prior to me entering into academia was healthcare design, which is why my research focuses on the planning and design of health system environments of care. So I've been a student of infection prevention through design for about 15 years now. And on this slide, I have a simulation of a biofilm, which looks to be protecting perhaps a methicillin Staphylococcus aureus bacteria and either an E. coli or Clostridioides difficile bacteria. So biofilms, for those of you who might not be familiar with the term, are the protective environment that surface-dwelling bacteria produce to protect themselves, propagate, and most importantly, pass antimicrobial resistant genetic material through conjugation. They are also very tough to get off contact surfaces in an interior environment, which poses a real dilemma in high-risk health settings such as hospitals. So my curiosity for infection prevention through design first started to manifest during my tenure as a healthcare designer. Hearing especially from infection control specialists in departments that regardless of how many hand sanitization devices we would specify and install in a hospital, there was no guarantee that everyone who entered the hospital was going to practice optimal hand sanitization in any consistent way. Additionally, it was shared, and research supports this, that environmental services staff sometimes do not have enough time to thoroughly clean patient treatment rooms, especially if a unit is at capacity. So considering that my doctoral studies are in system science and engineering, this curiosity developed into wondering if it was possible to engineer environmental systems to be robust and adaptive to human or procedural error that caused infection risk. And this question then really evolved to be, how essentially do we design and build environments more resilient to infectivity? Now, resilience is becoming an increasingly widely used term in design and building sciences, and it's obviously a core of the institute I work for, FIBER's research mission. However, it's also a term that is widely used in a variety of academic and study applications. So full disclosure, I bring my own interpretation to the way I understand the construct of resilience. My graduate degrees are in psychology and systems engineering. So this is the way I have learned to define resilience, and it may differ a little bit from the way it's defined in other knowledge camps. So psychology defines resilience as the behavioral qualities and attributes of an individual or community that enables them to thrive in the face of adversity or unanticipated circumstances. The next knowledge camp is engineering, which defines resilience as how elements of a system can sustain operations and evolve under expected and unexpected events in an efficient manner and evolve to an improved state of function. Now, the widely accepted definition of the concept of applied resilience engineering, since engineering, or the design of the built environment, is the context in which the research I'm discussing in this presentation is being operationalized, means the ability of an organization to anticipate, forecast, manage, and avoid hazards and threats to its primary performance goals. The second critical term for defining and the basis of this research is health systems infrastructure, which refers to human and engineered systems and resources intended to deliver or support safe patient care. Healthcare infrastructure in the context of infection control or infectivity prevention would then be those human and engineered systems which sought to support the delivery of safe and patient-centered care, as well as anticipate, predict, manage, and avoid hazards and threats related to hospital onset infection. So I'm sure most of us are aware that many bacteria are becoming increasingly resistant to antibiotics and antimicrobial treatments, and that this trend is unfortunately on the rise. So think about that for a minute. For those of us who know, we probably have some sort of elective orthopedic surgery like a knee replacement in the future. The fact that there might be a time when antibiotics given pre-surgery to control for the risk of infection are either less than effective or ineffective takes that option right off the table. So imagine how that phenomenon is going to impact the rest of your life or the life of a loved one. So on this slide, I've got some pre-COVID-19 statistics on antimicrobial resistant bacteria infection impact. In other words, it's a pretty safe assumption to say that none of these predictions have meaningfully improved outcomes since the publications of these studies from which they were drawn, which was prior to the COVID-19 pandemic. In fact, a 2021 published study that recently came out indicates that the progress that had been made in stemming the progression of some infection-causing bacteria has actually regressed as a result of the pandemic. So some important statistics that impact both community and healthcare and environmental safety as it relates to the threat of infectivity caused by antimicrobial bacteria includes that the rate of hospital clinical staff hand hygiene compliance is often less than 50%. When this data is reviewed by external review teams. More than 50% of hospitals in the U.S. report that they have an environmental services or EVS staff shortage. Those are the people that clean the patient rooms. Less than 80% of surfaces directly adjacent to patient care areas are cleaned at baseline intervals. So those in an inpatient setting would be that 4-foot to 5-foot radius around the patient bed. There's approximately 75,000 deaths in the U.S. that can be directly attributed to hospital-acquired infections, or HAI, per year. And this number has unfortunately stayed relatively consistent. 722,000 annually reported hospital-acquired infections, HAI, or nosocomial incidences occur in the U.S. annually. The predicted number of deaths by 2050 worldwide in regions of extreme poverty, primarily caused by antimicrobial resistant related health conditions, is forecasted at about 10 million. And the number of people by 2030 worldwide who live in extreme poverty, which is primarily caused by antimicrobial resistant related health conditions, is currently estimated to be around 24 million. So some of you might legitimately be asking by now, what does all of this have to do with architectural or healthcare design programming? And how does modeling socio-ecological factors as a way of informing health, safety, welfare planning strategies come into play? Well, as most of you listening to this presentation know, conducting environmental scans of patient catchment data is pretty common and architectural programming for healthcare facilities. However, the evolving effects of both hospital and community onset infections due to antimicrobial resistant bacteria are increasingly requiring the adoption of more accurate and adaptive methods for presenting an analysis of outside design basis factors that can impact healthcare design performance and moderating infectivity risks. So what are those outside design basis factors? they're basically the factors that we don't necessarily know of when we are designing a healthcare facility or even conducting programming for that might exist within the community that is actually receiving care in a hospital environment. So using the whole building design rubric for architectural programming, we can see that this process involves 6 basic steps, which includes researching the project parameters, establishing the goals of a project, gathering relevant information for the program, identifying potential design strategies or planning strategies that are relevant to the project, quantifying the requirements for a given project, and then summarizing the program. So let's begin by researching the project parameters, which for a healthcare environment design would include understanding those regional context variables the healthcare facility must contend with, or the environmental context in which it's going to be built, and also understanding the types of patients in the health system's catchment area the treatment setting is going to serve. So for the research we are currently conducting with a Florida-based hospital, this study process began with a literature-based discovery that targeted 2 specific types of antimicrobial resistant bacteria, which are understood to be particularly problematic in healthcare environments, both in Florida and worldwide. And these 2 bacteria are Clostridioides difficile, or C. diff, and Methicillin Staphylococcus aureus, or MRSA. And the parameters of the research reviewed included both hospital-acquired infections as well as community onset infections caused by these bacteria. The rationale for extending the scope of the frame of reference of C. diff and MRSA infections was due to the need to include socioecological variables that might be representative of outside design basis community factors that could contribute to an increased risk of hospital onset infections. In order to determine the types of social, economic, environmental, and demographic factors that were most closely related to the prevalence of these particular types of bacterial infections, a summative content analysis approach was taken. This method facilitated the determination of prevalence of themes in the 86 studies that were reviewed in this literature-based discovery. These themes were then parsed into composite socio-ecological categories of demography, underlying medical conditions, and environmental conditions. Environmental conditions contain the variable of environmental exposure, which represented the parameters of municipal and drinking water quality and the incidence of MRSA or C. diff infections, air quality and the incidence of MRSA or C. diff infections, and general toxin or pollutant exposure and the incidence of MRSA or C. diff infections. After the parsing of themes from the literature-based discovery was completed, further deconstructing of the socio-ecological parameters was performed. This process was driven by the availability of data that was regionally relevant to the health system partnering with us on this research. It was also guided by variables that had available consistent measurable values either through open source or proprietary information available through the University of Florida data repositories. Additionally, the underlying medical condition variables selected were based on their prevalence in the summative content analysis, the data availability of these occurrences, and their generalizability across hospital unit types. Environmental condition variables were selected by current discrete data availability and relevance to the regional catchment area of the health system partnering with us on this research. The resulting variables selected for inclusion in the analysis data frame were individual and healthy behavior factors, which included gender, age, race, and the diseases of diabetes and cancer. Social and economic factors, which included housing cost burden that exceeded 30% of income, homelessness, and renters or housing transients. Environmental factors, which included population, house overcrowding, which is basically defined as more than one person occupying a room on a full-time basis, as designated as overcrowded by the U.S. Department of Housing and Urban Development. People per square mile in the region, heat index, and air and water quality. And finally, community infrastructure, which included the variables of average index of medical underservice score, or IMU, number of people who are uninsured, COPD hospitalizations, and COPD ED visits. The Florida Agency for Healthcare Administration, or AHCA, Healthcare Region Delineation, was used to build a regionally relevant data frame that represented an adequate amount of data points of the parsed socio-ecological factors. AHCA is primarily responsible for the state's estimated $25.2 billion Medicaid program that serves approximately 4.5 million Floridians, and is also responsible for the licensure of the state's 48,500 healthcare facilities, as well as being responsible for sharing of healthcare data through the Florida Center for Health Information and Policy Analysis. Considering this, their rubric for designating healthcare regions within the state was deemed appropriate for compiling socio-ecological variables relevant to the health effects of MRSA and C. diff HAI. The counties selected for inclusion in the analysis are representative of AHCA Region 3, which is also representative of the general patient catchment area of the hospital collaborating with us on this research. The rationale for using grouping of representation of hospital catchment profile was to improve distribution normality of the socio-ecological model data for principal component analysis, reduce data dimensionality, ensure that they were relevant to regional health profiles within the state, ensure the data was relevant to regional health infrastructure and access factors, and ensure the data was relevant to state health approval for building design and construction. The resulting socio-ecological statistics within the data frame were compiled by AHCA Region 3 counties, evaluated based on their distribution to ensure normality, and standardized prior to analysis. Our team used supervised machine learning to identify regional and demographic factors that might be associated with regional incidences of MRSA and C. diff HAI. To begin this process, we used Pearson's R as a way to identify principal components in regional socioeconomic and demographic data as a way to determine the relationships between observed incidences of MRSA and C. diff HAI and socio-ecological factors endemic to the healthcare service region under analysis. What we were hoping to assess were obvious relationships in regional demographic parameters related to patient groups that could coincide with a high risk for spreading or contracting C. diff and MRSA infections within a healthcare setting. This analysis resulted in strong relationships between socio-ecological variables and incidences of HAI types that were expected based on the literature-based discovery, such as household crowding and the incident rates of MRSA, some that were unexpected, such as people per square mile and the incidence of C. diff HAI, and several commonalities in the relationship of certain socio-ecological variables and C. diff and MRSA HAI, which crossed a continuum of socio-ecological variable parse categories. Some of these included that a high number of uninsured populations were positively correlated with higher incidences of both MRSA and C. diff HAI. In areas where there were high numbers of renters, there was a positive relationship with higher incidences of both C. diff and MRSA HAI. And in regions where there were more people who were struggling with the health condition of diabetes, there was a greater number of reported C. diff and MRSA HAI. After the establishment of the principal components that appeared to directly correlate to the dependent variables of observed HAI, in this case MRSA and C. diff, we then used supervised machine learning algorithms to evaluate if there was indeed a significant relationship between the regional socio-ecological parameters endemic to the health system service region and the risk of certain HAI. In this case, we used ordinary least squares, or OLS, regression. An example of the outcomes was that the predictor that explained a high level of variance in the prediction of the dependent variable MRSA were high levels of uninsured populations, and a predictor that explained a high level of variance in the prediction of the dependent variable C. diff HAI was diabetes. Additionally, the predictor that explained a high level of variance in the dependent variable C. diff HAI was MRSA HAI, and vice versa. An important statistical outcome of this process was that it produced alpha coefficients, which were then used to weight the degree of infectivity risk based on the presence of certain regional parameters. This allowed for a likelihood of exposure level based on the degree of hazard event, in this case the hazards being C. diff and MRSA HAI. Additionally, this effort also helped the team to identify a hospital unit that best represented patients, which represented the socio-ecological factors deemed significant. Specifically, a unit that was comprised of several patients with underlying comorbidities that also struggled with socioeconomic challenges such as lack of health insurance or housing transients, which offered a clear depiction of regional infection risk impact on unit pathogen spread for in silico simulation. In the case of our clinical collaborators' opinion, they felt that the ICU would be the best fit for this data in continued scenario modeling. So although this process allowed us to answer the question of what is the risk level of hospital-acquired infections based on socio-ecological variables, it didn't really allow us to fully understand how effective an infective environmental component had to be to potentially cause hospital-acquired infections in humans. However, it did give us the opportunity to use a mixed methods approach that could then be used in the development of AI decision rule algorithms, which allowed us a better ability to predict the level of infectivity in hospital regional parameters, as well as the associated effectivity impact of resilient design interventions meant to moderate their impact. So for this, we are using fuzzy logic to determine the possibility level of system risk and design resilience. Now, for those of you who aren't aware, fuzzy logic has a unique ability to provide an appropriate logical mathematical framework to handle problems with vague and contextually mutable circumstances, such as regional infectivity and environmental infectivity. And one of the most beneficial aspects of this approach is that it derives possibilistic levels of event occurrence in the same way that human thought does in analysis, and therefore it's got the ability to summarize information into labels of fuzzy sets which bear an approximate relationship to the primary data under analysis. So, to demarcated fuzzy membership levels of regional parameter infectivity risks were then plugged into fuzzy inference systems to generate crisp outputs regarding the system's performance using a series of decision rule algorithms based on system risk and design resilience. So using the coefficients that we obtained from the machine learning OLS regression to establish the extent of the relationships between regional parameters and HAI allows us to define the system's risk prevention capacity categories. And these were demarcated into categories of somewhat low, low, and very low. And these can be generalized into determining resilience potential capability as well. So using health systems subject matter expert heuristic data to determine the performance of a system's resilience repertoire lent itself naturally to this effort, largely due to the fact that the fuzzy inference system methodology, which was being used for this analysis, is based on linguistic variables. So each of these characteristics were then translated into fuzzy membership levels for system risk response capabilities to external variable impact. And the membership for these resilience attributes are represented by a combination of triangular fuzzy number membership functions called T-norms and trapezoidal fuzzy number membership functions called T-conorms. These levels of risk prevention membership assignment average of hazard times effect times exposure use the OLS coefficients derived from the machine learning outcomes for the weighting of these regional hazard event levels. This approach allowed us to construct overlapping membership categories of performance output variables that were then aggregated to define a specific performance safety output capability based on fuzzy input variables. These categories can then be grouped by their perceived percentage level of systems resilience performance, and then apportioned into associated resilience performance membership functions. Basically, to evaluate the specific outcome of two fuzzy possibilistic levels of infection risk possibility and infection prevention design resilience potential, we use a method that allows us to derive the integral average of the relational intersection of these two factors related to the design of the healthcare environments called center of gravity. A fuzzy center of gravity outcome is where an intersection of two truncated disjoint fuzzy membership functions are evaluated to establish a crisp or specific output that would allow for an inference to be made about a consequent that would imply system infectivity prevention performance safety. This interpretation of this crisp consequent of the intersection of two fuzzy possibilistic outcomes of risk and resilience is governed by the aforementioned decision rule algorithms, which are derived from precedent data and in some case, expert heuristics. An example of one of these rules could be for the context of infection prevention. If risk prevention is low and system design resilience is strong, then system performance is safe. This exact approach for algorithm development was then executed for each of the categorically based socio-ecological variables deemed significant in the supervised machine learning analysis. So for example, in the socio-ecological variable category of demography, an associated decision rule algorithm of if county uninsured population proportion numbers are large, then MRSA HAI incident risks are very high, and C. diff HAI is undetermined based on analysis of data. An algorithm reflective of the socio-ecological variable category of environment would be that if the proportion of county home renters is large, then C. diff HAI and MRSA HAI incident risk is very high. And for the socio-ecological variable category of underlying medical conditions, an associated decision rule algorithms of if the proportion of persons with diabetes in the county is large, then C. diff HAI incident risk is very high and MRSA HAI incident risk is somewhat high. So when we use fuzzy inference systems algorithms like the ones we used in our research, this allows us to gain better insights into predictive safety outputs in environment of care scenarios, which can then be used for developing code for agent-based models. Agent-based modeling, or ABM, was developed from the field of complexity science, and the emphasis of ABM is primarily on the evolution of heterogeneous and interacting autonomous or fixed agents. Its modeling outcomes demonstrate how specific interventions can influence the characteristics, preferences, and behaviors of individual agents. Now, the benefit of using this approach, driven by fuzzy rule decision algorithms like the ones we've used, is that it allows us to evaluate the outcomes based on risk and resilience levels of autonomous agents and the performance safety level of environmental patches over temporal parameters and to spot patterns over multiple iterations. This allows us to better understand pathogen spread output on environmental surfaces within a healthcare environment through human to environment, and environment to human exchange iteration. It allows us to evaluate that if there's a change in surface infectivity input or a space layout, does this have any impact on the spread of infection output within a healthcare environment? And it also allows us to analyze how abiotic surface composition and cleaning iteration and effectivity level impacts the potential spread of infection-causing pathogens like MRSA and C. diff within a specific EOC. The benefit of this socio-ecological approach to determining specific hospital-acquired infection risk and necessary adaptive responsive environment of care systems framework is that it allows us to generate a series of predictive outcomes based on the intersection of risk and resilience fuzzy membership levels, and then to create generalizable decision rule algorithms. This basically allows us to have a type of operating system that can then inform agent-based model in silico scenario outcomes. These agent-based model scenario planning models then allow us to test multiple inputs iteratively over a series of multiple scenarios, which then allow us to spot patterns in environmental systems performance, which then allow us to make inferences about what types of environmental care planning paradigms might best contribute to C. diff and MRSA infection control goals in a way that's reliable. This research has led to the development of a process model that was patented by the University of Florida Innovate, listing the principal investigator and presenter of this session as first inventor, called the Resilience Inference System for Performance Safety, or RISPS model. So as a way to crosswalk architectural programming and using the artificial intelligence methods that comprise the RISP process model, we can see the following relationships that offer a way to integrate predictive modeling into the architectural programming process that is driven by socio-ecological data frames. This approach can then be used to ask the following questions during each stage of the whole building design guide architectural programming process. So for example, the first step of researching the project parameters, a reasonable question would be asking what is the regional health system context that the healthcare facility exists in. Establishing the project goals, a reasonable question would be, what are the infection prevention goals, which would contribute to the socio-ecological data frame development. Gathering relevant information during the project development process, a reasonable question derived from risk would be to understand what are the socio-ecologically driven outside design basis risk factors that would then be manifested in machine learning analysis. Identifying strategies for improving infection prevention through design of the healthcare facility, understanding what is the infection prevention through design performance safety potential, which can be derived from the fuzzy inference system decision rule algorithms, quantifying the requirements for high project performance. What are the effective design safety requirements, which can be manifested through the fuzzy inference system decision rule algorithm driven agent-based model scenario simulations, which are again based on the socio-ecological model factors. And then finally, summarizing the program, what is the infection prevention decision support through scenario planning. This goal with our current research with our hospital partners is to use all the socio-ecologically driven distributed AI modeling to create a kind of design programming environmental care planning dashboard that has the capability of determining the space design efficacy for moderating different types of hospital-acquired infection risk based on care delivery locations. This concludes my presentation on using socio-ecological models for guiding infection prevention through design resilience. If you have any questions on the content I presented, please feel free to reach out to me via email. Thank you.